to our meeting with Dr. Stacey Freedenthal. My name is Kate Sample. I'm with PESI, and I'll just be on here briefly to welcome you and thank you for being here. Dr. Freedenthal is a psychotherapist, a consultant, an associate professor at the University of Denver, an author, and the founder of the website Speaking of Suicide. Her work, decades of work, extends to all of our work as a mental health clinician, and we're thrilled to have her here. She is going to be speaking for us next week as part of our Clinicians Suicide Prevention Summit, which is on the 9th and 10th of September. It is completely free. You have an opportunity to earn some CE credit, network, ask the speakers questions. It's just going to be a phenomenal event about the assessment and prevention of suicide. So Dr. Freedenthal, I welcome you. Thank you for being here, and I can't wait to hear your answers to our questions. Thank you so much.
Well, thank you, Kate, for that lovely introduction, and I'm very happy to be here and happy to take questions about the ever important topic of suicide and its prevention. So I believe that the first question will pop up on the screen. Is that correct? Yes. So during the pandemic, more of my clients have been experiencing suicidality. How can I support them? This is such a good question and very, very important. Of course, it's always important, but the pandemic is making it, I don't know that I would say it's making it more important, but it's bringing it more to awareness. The fact that suicidal thoughts appear to be going up during the pandemic. Fortunately, so far, the evidence is that suicide rates have not actually gone up in the main. There are subgroups, and sadly, there's some evidence that among Black Americans, suicide rates are going up during the pandemic, while they're actually going down for other groups, such as white Americans. But that, those data are from the early months of the pandemic, and time will tell what happens in the months and even years to come. So to answer the question about how to support them, many of the basics apply that we would use during ordinary times as well as during the pandemic, which is to ask the client or ask your clients if they're having suicidal thoughts. Don't wait for people to bring it up. Use the word suicide or terms specific to suicide, such as, do you have thoughts of killing yourself, or do you have thoughts of ending your life? Many people use the phrase harm yourself or hurt yourself, but that's a different phrase. That's a different construct. A lot of people who are suicidal don't want to hurt themselves. They want the pain to end, and they think of ways to die that wouldn't hurt. And then many people who engage in self-injury aren't suicidal, or they're doing it as a way to cope with suicidal thoughts or to cope with other challenges. So having a conversation, not an interrogation, about suicidal thoughts, asking the person to tell you the story of how they came to think of suicide. And of course, there are a lot of risk assessment questions we do need to ask or learn the answer to, because sometimes those answers will emerge in conversation. But even if you have a standardized risk assessment you need to use, it's still important to ask and hear the person, because a bunch of yes/no questions isn't therapeutic for the client. They help us get information we need, but they don't help the client. And then specific to the pandemic, I would say, I say specific to the pandemic, but we can't really even be specific because the pandemic is affecting people so differently. Some people, they've had a loved one die. Some people have become ill and have long-term consequences of COVID. Some people have lost their job as a result of the pandemic. Many, many people have experienced social isolation or an extreme disruption in their regular life due to the pandemic. I know my mother recently visited a family in California, and it was the first time in 2 years for her to see her grandchildren. And that's her grandchildren in California, I should say. And that's just, very, very long time to go without seeing people you love and care about. So, and that's what the pandemic has done for many people. It's constrained travel, it's constrained daily interactions. I myself haven't been in my office since March 2020. And by my office, I mean my university office. So exploring how the pandemic has affected clients individually and not making assumptions about the pandemic overall, because everyone's situation is different. And I will tell you, I've even talked to people for whom the pandemic, I think this is a little taboo to say generally, because it's a huge tragedy on such a large scale. But there are people who will tell you that their lives have actually been improved, not by illness and death and loss and economic disruption, but by no longer having to have such a busy schedule and no longer having to be so extroverted all the time. If inside they're truly introverts, now they don't have to put themselves out there as much. Some people's business has increased during the pandemic. So, there are people who will report that they haven't had anybody die, they haven't gotten sick, they haven't lost their job, and that for them, the pandemic hasn't been harmful. So the suicidality that some clients experience may be independent of the pandemic. I've recently heard people saying that every suicide that occurs during the pandemic is because of the pandemic. And that's just not true. I mean, it's tragic, but every year in this country, we have tens of thousands of people die by suicide, roughly 45,000 in recent years. And that was pre-pandemic. So long story short, ask about suicidal thoughts, assess what the person's situation is and how the pandemic relates, and hear their story. And then if there are specific things related to, job loss or grief, to use the skills that we would normally use while keeping in mind the unique stressors of a global pandemic that seems to go on and on. So that's that question. Ooh, good question. How do I know when involving the police is appropriate? That is such a good question, because so many people, in the general public, but also in the clinical population, so many therapists talk about calling the police, and this should be absolutely a last resort that is very, very seldom used. I attended a talk in Denver some years ago with a very established psychologist. He didn't say to call the police, but he said the second somebody has suicidal thoughts, to send them to the emergency room. And if they won't go to the emergency room, then call the police. And this is just such unhelpful advice from the stance of a suicidal person. And I'm happy to tell you, most clinicians don't operate that way, but there is a certain subset who panic or who are preoccupied with fear or thoughts of their own liability. And I can't remember the statistic off the top of my head, but somebody did a study where they asked clinicians, if somebody says they're having suicidal thoughts, what's the first thing you do? And I think it was around 8%. Don't hold me to this, because I'm just saying it from memory, but I think it was about 8% said they called the police. And there's so many problems with calling the police that I feel like I shouldn't even have to explain them, because so many of them are obvious, especially these days with so many public, well-known cases of people being shot and killed by the police. And there's some research that shows that a huge proportion of fatal shootings by the police result from a loved one calling for a welfare check by the police or calling for assistance from the police. And that's not therapists, that's family and friends usually. But still, my heart goes out to people who call the police with the attempt to help their loved one and to help them stay safe, and then another tragedy results. So clinicians should avoid calling the police unless necessary, and I will talk about necessary, but because of the possibility of violence against that person, but also it's traumatic. It's traumatic to have the police show up. I know of people who were handcuffed when the police were called because they have suicidal thoughts. And there are a few things that I can think of that would be less therapeutic than handcuffing a suicidal person and putting them in a police car and taking, you know, in front of their neighbors and friends and all of that. So when do you call the police? I'm going to think of some situations. If somebody has a firearm and is aiming it at people or at you, or, and you know, arguably if they have a firearm at all, then call the police because there's extreme danger and you can't handle that yourself. You can't disarm somebody yourself. Call the police, but also know that their being armed increases the chances that the police will kill them or shoot them. If somebody is endangering people around them, if somebody is in a state of psychosis, and by psychosis I mean floored psychosis, not where they're hearing voices that they may be able to manage and cope with, but psychosis where they are so out of touch with reality that they are placing the people around them and themselves in danger and unable to think rationally. You know, just very extreme situations. If somebody, I called the police once many years ago because somebody came to my office after having attempted suicide, I mean, like minutes earlier, and wouldn't accept my suggestion of calling an ambulance for help. They were in the midst of a medical crisis and they fled the office. So I called the police in the hopes that they would be found and taken for medical assistance, and they were. So just really, I mean, I hope that those examples give a picture of it's appropriate to call the police if the situation is out of your control or out of the person's control, and people are in danger. And arguably, I mean, I would say if the person is in danger, but then it becomes so subjective and the line moves and people will say just having suicidal thoughts means the person's in danger, so the police should be called. And no, that's not true. We should never call the police just because somebody has suicidal thoughts. What can help me break through clients' chronic suicidal thoughts? Such a good question. These are all really good questions. And I do have a post on my website, speakingofsuicide.com. I think it's called When Suicidal Thoughts Don't Go Away. And it's for people who experience chronic suicidality, but it could also be useful for clinicians to read to see, you know, what the advice I give is. And that advice, or the advice I would gear towards this question specifically is not to try to break through the client's chronic suicidal thoughts. And I know that sounds really paradoxical, that what can help you break through the client's chronic suicidal thoughts is to not try to break through the client's chronic suicidal thoughts. And by that I mean, when somebody has chronic thoughts of suicide, it's usually become a habit of the mind. I've had clients who have thought of suicide for decades, maybe not persistently every day, but whenever they feel vulnerable, suicidal thoughts, they don't come knocking on the door, they just walk right in. There isn't even a door anymore. Yeah. The door has been removed. And Frank King is a comedian, but he's speaking seriously when he talks in a TED Talk about how when the smallest thing happens to him, his mind immediately goes to suicide as an option. And he gives the example of if he takes his car to the shop and a mechanic says, I think the example is you need new tires. I'm not sure. It's some kind of work on the car. Let's say it's you need new tires. that most people have two options: get new tires or don't get new tires. But for him, it's three options: get new tires, don't get new tires, kill yourself. And people laugh when he says this in the TED Talk. And he says, yeah, it sounds funny, but it's true. And so we're not going to be able to help some people get rid of their suicidal thoughts because they've become a habit, a cognitive habit. But what we can help them do is to relate differently to their suicidal thoughts. So rather than trying to get them to change those thoughts, help them to work from a stance of acceptance of those thoughts while helping them learn skills to distance themselves from the thoughts, to not take them so literally. And this, if you're familiar with acceptance and commitment therapy, this would be using cognitive diffusion, so that, and not only cognitive diffusion, but also the transcendent self, where they can observe themselves having suicidal thoughts. So like one tool that has been exceptionally helpful with clients I've worked with, it's so simple. It is so simple and yet powerful, is for people to restate their suicidal thoughts by prefacing them with the words, I am having the thought that. So that instead of saying to themselves, I should kill myself, now they're saying, I am having the thought that I should kill myself. And that effectively distances themselves from their thoughts and allows a sort of metacognition to occur, which then can make the thoughts less dangerous and threatening. So certainly, if somebody can challenge their suicidal thoughts and learn to and make changes or experience changes in their life that dissipate the need for suicidal thoughts, that's wonderful if they don't think of suicide anymore. But many times suicidal thoughts will persist, and then the challenge is to relate differently to them. Rather than changing the thoughts, changing one's relationship to the thoughts. Are safety plans really helpful? Yes, they are. They're very helpful. There's actually been gold standard research on this. And by that, I mean randomized controlled trials, where in one study, safety plans were compared to what's called a contract, and safety plans were more effective. In another study, safety plans were compared to treatment as usual, which usually was just giving referrals. And safety plans were effective at reducing suicide attempts, at reducing hospitalization. Safety plans are effective. Safety contracts, there is not evidence that they are effective. And this can be so confusing for students and new clinicians and even seasoned clinicians, that safety plans are not safety contracts. They sound so similar. But a safety contract is when you have a client promise not to do anything in their life. And sometimes it's an actual contract that they sign saying, I will not attempt suicide. And sometimes it'll say, without first going to an emergency room or calling my therapist or something else. A safety plan isn't a promise. A safety plan is, instead of telling you what I need you not to do, let's talk about the different things you can do when you have suicidal thoughts. And by can do, I don't mean I'm giving you permission. I mean, let's talk about the different options you have, and try to problem solve around what you'll do when you have suicidal thoughts. A safety contract is kind of a wish. You know, I mean, if a client comes to me for help because they're having suicidal thoughts, and if I say, I need you to promise not to kill yourself, that's sort of like somebody with chest pain going to a cardiologist, and the cardiologist saying, oh, I need you to promise not to have a heart attack. You know, that's a wish. And there's a phrase, a wish without a plan. Hope without a plan is a wish. You need a plan. So if the goal is for the person not to kill themselves, instead of telling them don't kill yourself and promise not to kill yourself, we need to talk with them about what are the things that you will plan to do instead. And typically with a safety plan, it starts with them recognizing the warning signs that suicidal thoughts are brewing or have already arrived. And then what are things they can do to distract themselves? I think of it as concentric circles, sort of like first it starts with them and then it slowly branches out to other people. So what can they do to distract themselves? Then who are people they can be with or places they can go to distract themselves? So first it's what can they do when they're alone, then with other people or in different places. And then who are people they can specifically ask for help, family, friends, teachers, ministers, pastors, rabbis, whatever their social support network is. And then we get into professionals that they can ask for help. And then another piece of safety planning is removing things from the environment that they might use to kill themselves, and firearms are especially relevant here. Having, ideally, if somebody has suicidal thoughts, they will not have a firearm in the house. However, this is the United States. Many, many people own guns and are passionate about owning guns, whether for reasons having to do with safety and protection or individual liberties, whatever the case. And so there are intermediate steps that people can take while keeping guns in their house that still would reduce the danger, such as using a gun lock, a trigger lock, having something by the firearm that is a reminder of reasons for living, different things like that. And then sometimes the safety plan, it depends on which version you're using, will ask the person to identify the most important reason to them for staying alive. So short answer, yes, safety plans are really helpful. And suicidesafetyplan.com has a safety plan. I also see there's a question in the chat, what is the website? And I think that might have referred to my website that I mentioned before, which is speakingofsuicide.com. It's primarily for people who experience suicidal thoughts and family and friends, but there's also a section for mental health professionals. So let me see the next question, please. I have felt panicked when working with suicidal clients. How do I stay calm? Also something I've written about on my website. And I wish I remembered the title. It's from years ago, but it's something about therapists panicking. The biggest way to stay calm is to get training in suicide assessment and intervention. Unfortunately, studies of graduate programs in psychology and social work and counseling consistently show that training in helping suicidal clients is minimal and sometimes not existent at all in coursework. Hopefully, in places where there's no coursework on suicide assessment and intervention, there is training in practica, hopefully, but that's not always the case. And even when there is training in the coursework, sometimes it's only 2 hours in an entire graduate program. There's research that shows that training increases competence or feelings of competence. By that, I mean perceived competence. And perceived competence increases confidence, which can enable people to stay calm. So that's my biggest piece of advice, is to get training or to undertake independent learning, read books on suicide assessment and intervention. There's really good videos on YouTube if you want to see sessions in action. I mean, there are pros on YouTube who, really, these are extraordinary times we live in. I'm old, so I remember when all these resources weren't free. And now you can go onto YouTube and learn many skills. And one of them is that you can improve your skills in working with suicidal clients. Other things that you can do are keep the lines of communication open with your client. One of the biggest areas of panic that I've observed in my consultation with clinicians is that they don't know. They don't know what their client is thinking and feeling. And sometimes that's because clients withhold, but sometimes it's because they're not directly asking. And then another thing I would say, and I don't want to minimize the danger of suicide and suicidal thoughts, because as I mentioned before, tens of thousands of people die by suicide in the United States a year, and many, many more attempt suicide. So I don't want to be dismissive whatsoever of the danger, but I do want to point out that roughly 12 million people in this country report having suicidal thoughts based on research. And I don't mean at any given time, I mean in the previous year, 12 million people seriously considered suicide. And so again, I want to be very careful because 45,000 deaths are a huge tragedy. You know, they're 9/11 occurring many, many times over in terms of the loss we experienced on that day. So I don't want to minimize that. But it is something to keep in mind that suicidal thoughts by themselves don't mean that death is imminent or that hospitalization is necessary or that panic is warranted. You know, so if you can hold on to the fact that suicide is still, thankfully, an uncommon event, not uncommon enough, but it is uncommon, and maybe that can help soothe you too, that not to think, oh, this person isn't going to kill themselves, because very few people do, but to remind yourself, because that wouldn't be helpful, but to remind yourself that it's not always the case that people who have even serious thoughts of suicide die, and that can help you to maintain calm. I do want to say that I observe that some people, the way they stay calm is they adopt this kind of nihilistic attitude. I might be mispronouncing it, nihilistic attitude of well, if somebody wants to kill themselves, there's nothing I can do. And that's how they cope with their anxiety. So rather than feeling a huge sense of responsibility and panicking as a result of feeling kind of totally responsible for the person, they absolve themselves of responsibility. And that's not a solution either, because there is something we can do. If we are a mental health professional and we know that someone in front of us is having suicidal thoughts, then we have a very special opportunity to try to help this person to experience hope, to enlarge their perspective, to recognize that there are different ways of thinking of things and of doing things, to identify changes they can make in their life to help themselves feel better. And in very extreme circumstances, they may need a higher level of care that we can help them get to. So I don't mean to say that if somebody dies by suicide, it means the therapist did something wrong, because there are other factors to consider. But I do mean to say that we absolutely should do what we can to help a person not only stay alive, but to want to live.
Yeah, I thank you so much, Dr. Freedenthal, for being here and for sharing your insights. I was saying to our group on the PESI chat behind the scenes here that there's so many great little thoughts and nuggets and things to take with you as a clinician as you're working with this issue. And if this is any indicator of your presentation at the Suicide Prevention Summit, we're all very excited to have you there. And thank you so much for sharing your time with us today. Everyone, we are thrilled to have you here. We hope we will see you next week as well. Thank you again, Dr. Freedenthal, for being here and sharing your insights and your expertise. Thank you. We hope to see you guys soon.
Can I say one thing?
Please, yes.
Okay. So first of all, thank you. That was nice of you to say. Second of all, I am presenting at the summit, and my presentation will be called Helping the Suicidal Person, a Clinical Toolbox. And I also want to say I see some comments in the chat, some questions that I wasn't able to see before because I was focused and because we don't have time for me to answer. But if you'd like, please feel free to, if you use Twitter, to ask the question on Twitter. And I will, tag me and I'll answer the question. Or you can go to my Facebook. I have a Speaking of Suicide page on Facebook. I also have Helping the Suicidal Person on Facebook. That's another page. And also a professional page for myself. On any of those pages, if you want to post a question, I would be happy to answer it. Or even on my website if you want to submit a question.
Wonderful. We always like to know the path to learn more from our speakers. So thank you for sharing all of that. It looks like they're posting it too, which is great. So thank you so much, everyone. We hope to see you next week. Dr. Freedenthal, thank you.
You're welcome. Thank you.